from
Sure.
Dr. Jagannath, we heard what it was like in a quote unquote hot zone. You are not in one of those quote unquote hot zones. So how are you dealing with this? How are you preparing and for a possible increase? And what are some of the lessons that you've been learning from colleagues like Dr. Jagannath?
Well, that's exactly right. We haven't had this overwhelming pandemic like we've had in New York, in China, in Italy. So we have been looking very closely at the experiences in those locations and trying to act proactively to do what we can to minimize the amount of infections. It's really, first of all, I'd like to thank you for getting this all put together, because we were having those conversations about having people come out to New Mexico. And when you asked me in February, should we be bringing people out, we already had a travel ban in place. So I'm impressed that you were able to put this together. And it's a very timely topic because it's a big part of what we're doing every day, even with our myeloma patients. They're constantly asking, what should we be doing and how does this impact us? And then we have some more subtle conversations about what to do with their treatment and whether there should be changes made. The American Society of Hematology has also made recommendations for individual different diagnoses, and there's specific recommendations for myeloma. So we're taking a look at those things as well, but also considering where we stand in this. It is very dynamic. It changes week by week. So we assess what our resources are in the clinic. We've made changes there to make people safe. We assess our inpatient resources, and that's changed a lot too, and I can get into that a little bit. So we are definitely trying to learn from the experiences of others so that we don't have to repeat all of that here in New Mexico. That being said, it's expected that our peak number of cases will be in the next few weeks. So we're sort of seeing how that will play out. All of us subspecialists in hematology and oncology, we've sort of been drafted to cover inpatient services should they become overwhelmed there. And so we sort of are on the list of, to help take over. Right now, it's kind of like the calm before the storm in a sense, or maybe if you think about a tsunami, they say the water goes out first before the tidal wave hits. And that's true because a lot of people have been staying away from clinic. We've been doing a lot of telemedicine, which is really sort of a new thing. And in the hospitals, a lot of elective cases and surgeries have been canceled. So the hospital sort of cleared out, which was actually quite a benefit because our UNM hospital is a county hospital. It typically runs over capacity, and I really was worried how we would manage an influx of patients. But the fact that the census went down really increased our capacity, and so I think we're actually in a good situation, and I expect we won't become overwhelmed.
Okay, well that's promising news, certainly, and we hope other colleagues in your positions are gonna face the same things. Now, you treat myeloma. You're also a bone marrow transplant specialist. How do you deal day to day with people who have active myeloma during this time? They may need a stem cell transplant. They may need infusions. What are some of your strategies that people should be thinking about, and how flexible should they be?
It's very much individualized. So there's not one solution for everybody. And I think that was a question in the Q&A that I answered as well. The question was, should folks with myeloma do something different than other patients? Well, this has been changing with the recommendations for the general population. It has changed. First there were travel restrictions, and then now there are stay-at-home orders here in New Mexico. And so those things apply, of course, but myeloma varies a lot from patient to patient. The status of the myeloma either may be in remission or it may be progressive and you need treatment. The general recommendations from the American Society of Hematology is not to withhold treatment, but definitely considerations need to be made. There are some treatments that can be done orally, where you may not need to come in to the clinic all the time for infusions, and we're doing more of that. We have postponed all of our bone marrow transplants during this peak phase. We don't want people to be in the hospital if the hospital's overwhelmed. We don't want them to be exposed. But also after bone marrow transplant, you develop a lymphopenia, a low lymphocyte blood count that lasts for several months. Even though the recovery is quicker in terms of neutrophils and your red blood cell count, that low lymphocyte count may be a risk factor for bad outcomes with COVID-19. That's been shown in a number of studies out of China and elsewhere. And so we don't want to put a patient into a situation where they would be at increased risk right when there's a lot of the virus present. That's a little different than some other treatments. So there are other treatments that you can do as an alternative that may not knock that lymphocyte count down so much. And so that's what we would consider. And generally speaking, the timing of a transplant is pretty elective, even though it's a standard treatment and we still recommend it. It's not essential that typically that it happens immediately. So we will collect stem cells, put them in storage, and then we'll decide when the best time is to proceed.
Okay. Now, I've been so, like, as I said before, I'm so interested in the type of research you do, and your research in particular focuses particularly on molecular mechanisms in cells and how they go awry in organ tissues. And to me, as a layperson looking at the effects of COVID, that sounds fairly familiar. Is there any overlap between the type of research that you're doing now that can inform COVID research?
Well, I'm not an infectious disease specialist. We do laboratory research on the pathogenesis of malignancies, but I actually do have just coincidentally some collaborative work that's ongoing with infectious disease doctors at the University of Washington, where this was sort of the original epicenter in the country. We are actually testing antiviral drugs to see if they may increase the risk of susceptibility to certain cancers. So there's some indirect connections there, but I can't say we're directly working with COVID-19. I've kind of become a little bit more informed about antiviral drugs. So I've been interested to hear about this research coming out with a cocktail of antivirals that may be beneficial at eradicating the infection or speeding the eradication in COVID-19 patients.
Okay.
As Dr. Jagannath indicated, I think it's remarkable that we haven't seen that cancer patients per se are at a remarkable increased risk. That may be for lack of data, but there's also some other surprises with people with cardiovascular disease and diabetes. Obviously, pre-existing pulmonary disease is a problem since this is a respiratory infection. But those other patients, so there may be a cardiovascular component to the disease as well, where the heart or blood vessels get involved and get infected. We know patients with the most severe disease, they have a viremia, the virus is in the blood, it gets into the gut. Dr. Jagannath mentioned patients having diarrhea, et cetera. So it can, in the most severe cases, it becomes systemic. It's not all just about the lungs and the airways.
I had a conversation with Dr. Aliwadi in Mayo Jacksonville a couple of months ago about how we knew that that this pandemic would expose health disparities, and it has. And in New Mexico, you have really some unique types of health disparities in terms of Latino communities, Native American communities, and especially rural people who live in extreme rural conditions. Can you tell us how you deal with that?
Well, that's absolutely right. So thank you for bringing it up. Here in New Mexico, the most cases are in the metropolitan area of Bernalillo County, which is where Albuquerque is located. But that's not surprising because that's nearly half the population of New Mexico. However, if you look per capita, there's really been a disproportionate number of cases to the west and northwest, which is up into the Navajo Nation. And there's about 3 times as many cases there and fatalities. And that definitely is a resource poor area. They have less access to care. They live in oftentimes in smaller dwellings, more people per dwelling. And then the cultural practices may impact that as well. I have a patient who lives on a local pueblo who said it just now hit their pueblo And a lot of cases thought to have occurred because of a funeral where the whole pueblo had gathered, and and apparently a lot of people had gotten exposed. So that's definitely a big problem. I was just on the Indian Health Services website earlier, and I can see that they really are doing an admirable job of trying to address this. They're tracking the number of cases, how many deaths, and really trying to provide information for that community in particular. We are used to people having to come long distances. When I was a resident at the Mayo Clinic, people would come from all over the world. Here, people are used to getting in their cars and driving long distances. So we are managing a lot of that with telemedicine now, which helps minimize people's need to come into clinic, possibly get exposed. And in myeloma, you can do a lot of that if you can get a decent blood test on them, check their blood work and their myeloma markers. Then, in the short term, at least, you can really do a lot without having to expose people.
Okay. And then I have two sort of unfair questions that I've heard a lot from patients, so I'm going to go ahead and pose them. What do you wish you knew 2 months ago, knowing what you know now? And then take out your crystal ball and how do you see, what are some of the things that you're thinking about that might be our world 6 months from now? Our world meaning the myeloma community.
Yeah, 2 months ago, back in February, I think like a lot of us, I probably minimized this, thinking, yeah, this is in Italy and this is Europe and China. Maybe it'll miss us, it'll pass by or what have you. I don't think that we were completely naive, though. We were paying a close attention to things, and a lot of preparations were being made. And as soon as information came out, we really tried to take that to heart. And we've thought a lot about where do things go from here. I think one of the big questions I have, and I don't think there's been enough attention paid, is how do we get out of this certain situation? Like, where do we go from here? One big thing, of course, that's happened, I think, nationwide is that people are in their governors or their states has said that they should stay at home. That's a huge economic cost, and it's not a long-term solution because it's absolutely effective if you're not exposed to other people. But if you're still susceptible and go back and you stop this and go back into the community and it's still out there, then you have to have a longer-term solution that can prevent just a resurgence of the disease. One of those things, of course, is if people are immune. If we have a vaccine, people can become naturally immune if they've exposed. So New York City, may have the benefit where a lot of people have been exposed, and so therefore they won't spread the virus around once they've cleared it out of their system. But short of that, I really hope that we learn one thing that might come out of this is that we can learn from the myeloma community and bone marrow transplant communities. How do you have proper hygiene when you're in public? How can you be respectful if you have a cold and cough and have good hygiene and not spread that to other people? I'd like to see people wear masks on airplanes if they have a cough or sneeze. I'd like to see people just be more conscientious about that. And that won't just help COVID, that'll help influenza and things that we're dealing with parentally.
I always say that, to be a myeloma specialist, you basically go through medical school every 3 years of your life. You're constantly in medical school when you're a myeloma specialist or a hematology specialist. What is that like with COVID? I mean, how much time are you able to spend reviewing literature, doing what you normally do as a doctor and a researcher? And how does that affect your everyday practice?
I feel as a myeloma doctor, I'm constantly in medical school. And I think one thing in medical school you learn is that you can't know it all, and you have to sort of learn how to learn and stay apprised of what is new and be humble and realize you don't know everything. So the coronavirus or COVID-19 has definitely become a major subject of all of our conversations with patients. We try to educate them. I think they do have the benefit, especially if they've been through a bone marrow transplant, about knowing something about personal hygiene and safety. And so they're one step ahead in that way. If if their disease is in remission and they have normal blood cell counts, I don't think that they're at particular risk compared to other patients. So I think in a way they're kind of a step ahead. but it has become definitely a major part of our daily communications. It takes longer to get through a discussion when you're trying to do it on the phone, and you have these additional concerns.
Okay. And finally, I'd like to get just a little personal because one of the things that you and I share, or I should say your children and I share, is that we have grown up firmly with one foot in the United States and one foot in Europe, specifically Germany. And all of our patients and all of our doctors are constantly traveling internationally. When we are able to travel internationally again, how do you think that's going to be different? Or is that something we should even be thinking about now?
I'm not so sure international travel versus travel in general is an issue. I think that hopefully we can learn as a nation to make travel a little safer. Here in New Mexico, there is a genomic specialist who has done sequencing on the coronavirus that patients have acquired, and because of the subtle mutations that happen in the virus, you can actually determine its pedigree and determine where it came from. And so most of the cases have been directly linked to travelers, and most of those travelers were coming from Europe or New York, and didn't realize that they had the infection, of course, and then started a little cluster of infections. So I do think that travel is important, and we should learn how to travel safely. You know, nowadays we're all crammed into these little spots in airplanes, and I'm not sure, we always worry about the airflow in the airplane, but I hope that we can, learn to cover our coughs and maybe have hand sanitizer and maybe wear masks in the airplane if we have URI symptoms, and that can just help overall. But on a personal note, it is impacting us as well as a family. My daughter's in Washington State, so here's a shout out to Michelle, who is she is a floor nurse at the biggest hospital in the city, and her whole floor is coronavirus patients. So she has had to learn very quickly how to deal with that. I think there was a lot of stress on the nurses, and so I really think they should take the credit for being the ones who are on the front line and dealing with this every single day.